Dear student, I am Dr. Prakash Mungli, a professor in biochemistry. I did my MD in biochemistry from Kasturba Medical College, Manipal University. In this video, I will be explaining you all about vitamin B12, which is cobalamin. Now, vitamin B12, which is cobalamin, is a hematopoietic vitamin along with folic acid. So, both cobalamin and folic acid are hematopoietic vitamins. And this is one of the complex vitamins of all water-soluble vitamins. And also, it is a unique among all vitamins because it contains a cobalt atom in the center of the molecule, as you see here. And one of the role of cobalt in cobalamin is it is part of vitamin B12. Now, there are four forms of vitamin B12. One is cyanocobalamin, other is methylcobalamin, third is deoxyadenosylcobalamin, and the fourth is hydroxycobalamin. So, these are the four forms of cobalamin and they have their own functions in our body. First, let's look at deoxyadenosylcobalamin. This deoxyadenosylcobalamin, it is the coenzyme for an enzyme called methylmalonyl-CoA mutase. And this methylmalonyl-CoA mutase enzyme, it is involved in the conversion of methylmalonyl-CoA, which is a 4-carbon molecule, into a succinyl-CoA. And this is what methylmalonyl-CoA mutase does. And now, methylcobalamin, role of methylcobalamin. Methylcobalamin, it is needed for an enzyme called homocysteine methyltransferase, which is also referred as methionine synthase. This homocysteine methyltransferase, it is involved in the conversion of homocysteine into methionine. As you see here in the reaction, homocysteine is methylated to become methionine and the methyl group donor here is N5-methylcobalamin. Our next methylcobalamin is another form of vitamin B12 and it is required for the conversion of homocysteine into methionine, and this is done by enzyme homocysteine methyltransferase. And here methylcobalamin is converted into cobalamin after donating a methyl group, while homocysteine is converted into methionine. So, conversion of homocysteine to methionine, it is a methylation process done by homocysteine methyltransferase, where methylcobalamin is converted to cobalamin. Now, what will happen to the cobalamin? Cobalamin has to be converted back into methylcobalamin, and for that a cell needs a methyl group donor, and that methyl group donor is N5-methyl tetrahydrofolate, and this N5-methyl tetrahydrofolate will give the methyl group and converted back into tetrahydrofolate, while cobalamin is converted into methylcobalamin, and this is what happens. So, what happens to the tetrahydrofolate now? This tetrahydrofolate can go into variety of tetrahydrofolate formation. So, meaning this is the only reaction in our body where N5-methyl tetrahydrofolate is converted back into tetrahydrofolate so that this tetrahydrofolate can get into variety of tetrahydrofolate derivatives. So, while this reaction is going on, methylcobalamin is converted into cobalamin, thereby it is converting homocysteine into methionine. So, the conversion of homocysteine into methionine is done by methionine synthase, and that needs methylcobalamin. This is the second function of cobalamin in our body. So, the first function of cobalamin is conversion of methylmalonyl-CoA into succinyl-CoA done by deoxyadenosylcobalamin as the coenzyme for methylmalonyl-CoA mutase enzyme. And the second function of cobalamin in our body is conversion of homocysteine into methionine done by homocysteine methyltransferase, which is also called as methionine synthase, where methylcobalamin is converted into cobalamin while homocysteine is going into methionine formation, and then the cobalamin is converted back into methylcobalamin, and for that N5-methyl tetrahydrofolate gives the methyl group and it is converted itself back into tetrahydrofolate, so that tetrahydrofolate can go into different tetrahydrofolate forms in our body. Now, the third type of cobalamin that we have here is the hydroxycobalamin. Hydroxycobalamin is a natural form of cobalamin which is synthesized by the bacterial flora, and this type of cobalamin can be converted to various other forms of cobalamin. Now, the fourth type of cobalamin that we know is cyanocobalamin, and this cyanocobalamin is an artificial form of cobalamin which can again be converted into any other forms of cobalamin. Now, let us get into sources and dietary requirements of cobalamin. Note that cobalamin is neither synthesized in humans nor synthesized in animals, but animal cells, but it can be synthesized in the intestinal bacteria of especially in the ruminant animals. So, neither human nor animals can synthesize cobalamin. Cobalamin is solely synthesized by the bacteria. So, where exactly these, what kind of bacteria can synthesize cobalamin? Cobalamin synthesizing bacteria are generally present in ruminant animals. Example like cows, where the intestinal tract is longer and the bacteria have sufficient time to ferment the food material and make some of the cobalamin, and that cobalamin is absorbed by that particular animal, get into its tissue. And when a person consumes food derived from animal origin, and that's how we get cobalamin, once the one that is synthesized by the bacteria in the intestine. Now, the liver is a rich source of cobalamin because majority of the cobalamin that is absorbed by the animal, ruminant animals, will be stored. 50% of that cobalamin is stored in the liver, rest is stored in the kidney, muscle and other things. So, kidney, meat, eggs, milk and cheese are the good sources of cobalamin also. Now, coming to the dietary requirements, so cobalamin is required only in micrograms per day. That means requirement is very small amount. In infants and children, it is just 1 to 1.5 micrograms. In adults, it is 3 micrograms per day, and during pregnancy and lactation, it is 4.5 micrograms per day. And note that cobalamin, it is concentrated in the liver of animals in 3 forms: methylcobalamin, deoxyadinosylcobalamin and hydroxycobalamin. And vitamin B12 that is isolated from natural source is called as cyanocobalamin because it contains cyano group, which is essential for chelation of cobalt ion. Now, coming to absorption and transport and distribution of cobalamin. Let's divide that into how this cobalamin is absorbed and transported from the stomach all the way to the terminal ileum, and from there into the portal circulation, and from there to the tissue. Okay. So, the first thing is what happens in the stomach. So, in the stomach there is acid hydrolysis of vitamin B12 from its bound form, and it must be released as a free form of vitamin B12, and that is done by acid hydrolase enzymes. And protein in the intestine, especially in the duodenum, the trypsin digestion of a protein in the intestine can happen, and it can release that particular protein bound vitamin B12. So, in the stomach there is acid hydrolysis going on, and the R binder protein. This R binder protein is a glycoprotein that is released by the salivary glands, and it needs acidic pH to bind with this free cobalamin. Thereby, we have a vitamin B12 R binder complex, which is entering into, which is there in the stomach, and from there it enters into duodenum. So, what happens in the small intestine? So, in the small intestine, R binder, it will be digested with trypsin because R binder is separated from the cobalamin because of the alkaline pH which is there in the small intestine, and this R binder, it is digested by the pancreatic trypsin enzyme and separate cobalamin. And this cobalamin in the small intestine, it is going to bind with intrinsic factor, and this intrinsic factor, it is synthesized and secreted by parietal cells of the stomach. So now intrinsic factor cobalamin complex is formed, and this intrinsic factor cobalamin complex, it is passing down to the ileum, and as it is going to the terminal part of ileum, in the terminal part of ileum, we have something called as Cobalamin receptor, and this Cobalamin receptors are going to recognize intrinsic factor cobalamin complex, and this intrinsic factor cobalamin complex is endocytosed inside the enterocytes. Once it is inside, so the intrinsic factor cobalamin complex is separated, and now you have a free cobalamin in the enterocytes, and this free cobalamin in the enterocyte, so it is going to bind with a trans cobalamin 2. This trans cobalamin 2 is the protein that is helping in the transport of vitamin B12 from the intestine all the way to the tissues. Okay, so the trans cobalamin 2 is the transporter of vitamin B12. Now the methyl cobalamin, once it is transported to the tissues, and in the tissue cobalamin is stored as a methyl cobalamin, and that is stored by binding to trans cobalamin 1 and trans cobalamin 3. So around 2 to 5 milligram of cobalamin is stored in our body, total amount. In that 50% of the cobalamin is stored in the liver, and this much amount of cobalamin, that is 2 to 5 milligram of cobalamin, that is stored in our body, out of which 50% is there in the liver, it is sufficient to meet the cobalamin needs of our body for 3 to 6 years of B12 requirement. Okay, so let me explain you one more time to reiterate all the points that we have discussed using this particular figure here. So we have a dietary cobalamin which is entering into the stomach, and in the stomach this cobalamin is going to bind with R binder, and this R binder, it is coming from the salivary glands, also it can come from gastric mucosal cells, and R binder needs acidic pH which is there in the stomach, and it is going to combine with vitamin B12. Note that the parietal cells of the stomach also synthesizes intrinsic factor there into the stomach, but intrinsic factor is not going to bind to cobalamin in the stomach because intrinsic factor needs alkaline pH to bind to cobalamin. So it is going to wait all the way until it reaches small intestine. So in the small intestine, because there is alkaline pH, R binder is separated from vitamin B12. Now you have a vitamin B12 which is free, and that vitamin B12 is going to bind with intrinsic factor which is facilitated by alkaline pH. Now we have intrinsic factor vitamin B12 complex, and now this intrinsic factor vitamin B12 complex, it is going to go and bind with the Cobalamin receptor which are located in the terminal ileum. Make sure you remember this. Terminal ileum, that's where the Cobalamin receptors are present, and now the receptor mediated endocytosis will go on, and with the Cobalamin receptor, vitamin B12 is taken into the enterocytes, and for that you need intrinsic factor intrinsic factor vitamin B12 binding with the Cobalamin receptor. Entire thing is endocytosed, and inside the cell, Cobalamin receptor, intrinsic factor, vitamin B12, all of them are separated. Intrinsic factor will be digested by the lysosomal enzyme, Cobalamin receptors are recycled, and now you have a free cobalamin, and this free cobalamin which is there as methyl cobalamin, it will be binding with trans cobalamin 2 which is a transporter of vitamin B12 in the circulation. So basically vitamin B12 binding to trans cobalamin 2 will enter into portal circulation. From the portal circulation, 50% of this particular cobalamin is taken up by the liver. Rest 50% is taken up by other tissues. So once it enters into the liver or other tissues, transcobalamin is separated, and now cobalamin will bind with transcobalamin 1 and transcobalamin 3. So, transcobalamin 1 and transcobalamin 3, these are the storage form of storage proteins for cobalamin in the form of methyl cobalamin, which is bound to transcobalamin 1 and 3. So, there are 2 to 5 milligram of total cobalamin present in our body, out of which 50% is there in the liver, and this 2 to 5 milligram is sufficient to maintain the cobalamin needs of our body for 3 to 6 years. What that means? That means it takes 3 to 6 years for a person to go into cobalamin deficiency. Now, let's look at some of the causes for cobalamin deficiency. Now, the causes for cobalamin deficiency, it can be because of malabsorption of cobalamin in the intestine, or it can be simply because of inadequate dietary intake. First, let's look at what are the causes for inadequate dietary intake of cobalamin. So, it is seen in vegans. Cobalamin deficiency is commonly seen in vegans who omit meat, fish, eggs, cheese, or anything that come from animal source. And largest group of vegetarians in the world, like those who omit taking or restrict foods coming from animal source, they can be at risk of cobalamin deficiency, and that includes vegetarians, vegans and vegetarians. And infants born to severely cobalamin deficient mothers can also suffer from cobalamin deficiency. Coming to gastric causes for cobalamin malabsorption. So, what are the gastric causes for cobalamin malabsorption? First thing is atrophic gastritis. So, here H. pylori gastritis, H. pylori infection leading to atrophy of the parietal cells, thereby decrease in atrophic parietal cells, chief cells and all that, where there is a decrease in acidity in the stomach and decrease in the synthesis of intrinsic factor, will lead to decrease in cobalamin absorption, because intrinsic factor is important in the absorption of cobalamin from the terminal ileum by binding to tubulin receptor. Or it can be autoimmune gastritis, like what is seen during pernicious anemia. Pernicious anemia is an autoimmune condition. Usually it is associated with any other autoimmune disorders like Hashimoto's thyroiditis. Okay, so autoimmune gastritis, pernicious anemia, associated with any other autoimmune conditions. One of the autoimmune condition can be Hashimoto's thyroiditis. So, pernicious anemia associated with any other autoimmune condition. So, they will have, these patients will have autoantibodies against intrinsic factor. Thereby, parietal cells will be parietal cells are destroyed, and thereby decreases availability of intrinsic factor, and when the intrinsic factor is decreased, so vitamin B12 absorption mechanism is affected. So, atrophic gastritis caused because of H. pylori infection or because of autoimmune gastritis is one of the cause for vitamin B12 deficiency other than dietary deficient intake. So, it leads to, intrinsic factor deficiency due to atrophic gastritis will lead to cobalamin malabsorption. Coming to congenital intrinsic factor deficiency, that can also lead to cobalamin malabsorption, because it is there since birth. Intrinsic factor will be deficient in the child. Coming to gastrectomy, gastrectomy can be partial gastrectomy or total gastrectomy. So, when we remove stomach, so that means intrinsic factor is not coming, acidity in the stomach is not there, and that will lead to cobalamin malabsorption, because two things happens when stomach is removed, either total or partial it is removed. What happens is intrinsic factor coming from the parietal cells not there, and hydrochloric acid acidity is needed for binding of cobalamin R factor, that is also not there. Overall, it can give rise to cobalamin malabsorption, eventually leading to cobalamin deficiency. Or it can be ileal resection, where a part of the ileum is taken out, or it can be tropical sprue, celiac disease, small bowel bacterial overgrowth syndrome, or any fish tapeworm infestation, any parasitic infestations which will bind with vitamin B12. So, all this can lead to vitamin B12 malabsorption, or it can be disturbance in the enterohepatic circulation, can lead to cobalamin malabsorption because cobalamin is also secreted in the bile and returns back to the systemic circulation through enterohepatic circulation. Okay, disturbance in this enterohepatic circulation have a major effect on vitamin B12 status. Iron deficiency anemia can be associated with vitamin B12 deficiency because iron deficiency anemia can lead to gastric atrophy, and that gastric atrophy decreases parietal cell mass, and thereby it can lead to vitamin B12 deficiency. And it can be congenital transcobalamin 2 deficiency and nitric oxide inhalation. All these things can lead to cobalamin malabsorption. Now coming to a special concept that is associated with cobalamin deficiency called folate trap. Very important. You will have to understand folate trap because what happens in cobalamin deficiency is, so cobalamin, which is in the form of methylcobalamin, is helpful in the conversion of homocysteine into methionine, which we have already seen in the earlier slides. This conversion is done by methionine synthase, or it is so when homocysteine is converted into methionine, so the methylcobalamin is converted into just cobalamin. And what happens to this cobalamin? So we need to the cells need to maintain good quantities of or good concentration of methylcobalamin inside the cell. So because of that, so cobalamin has to be converted back into methylcobalamin, and that means we need a methyl group donor for that. And the methyl group donor in the conversion of cobalamin back into methylcobalamin, and that methyl group donor is N5-methyl tetrahydrofolate. And this N5-methyl tetrahydrofolate will be giving its methyl group and converted back into tetrahydrofolate, and while cobalamin is converted into methylcobalamin. So, see, the methyl tetrahydrofolate here is converted back into tetrahydrofolate. It's like freeing a tetrahydrofolate, and this tetrahydrofolate in the cell, it can go into different tetrahydrofolate forms. It can be N5, N10 methylene tetrahydrofolate, N5 formyl tetrahydrofolate, N10 formyl tetrahydrofolate. All this kind of tetrahydrofolate derivatives are made possible only when N5 methyl tetrahydrofolate is converted to tetrahydrofolate, while cobalamin is converted to methylcobalamin, and that happens when homocysteine is converted into methionine. So, homocysteine to methionine, cell is using methylcobalamin, converting that into cobalamin because only methyl group is taken, and the cobalamin is converted back into methylcobalamin by taking methyl group from methyl tetrahydrofolate, N5 methyl tetrahydrofolate, which is eventually converted into tetrahydrofolate, and that tetrahydrofolate goes into different forms of tetrahydrofolate molecules. Now, let us see what happens. So, if there is a cobalamin deficiency, what we will do now is, we are going to decrease cobalamin here. So, decrease in cobalamin will lead to decrease in the conversion of cobalamin into methylcobalamin, because cobalamin itself, vitamin B12 itself is decreased. When cobalamin is decreased, so that leads to decrease in the conversion of cobalamin into methylcobalamin. That means N5 methyl tetrahydrofolate conversion into just tetrahydrofolate is also decreased. So what will happen? There will be accumulation of this N5 methyl tetrahydrofolate inside the cell, because conversion of methyl tetrahydrofolate, N5 methyl tetrahydrofolate into tetrahydrofolate, that needs conversion of cobalamin into methylcobalamin, and now when cobalamin itself is deficient, so this N5 methyl tetrahydrofolate conversion into tetrahydrofolate conversion do not go on. So what will happen? The cell will simply accumulate tetrahydrofolate as N5 methyl tetrahydrofolate. It simply accumulates. So then that leads to decrease in the availability of free tetrahydrofolate, and when that decreases, so other forms of tetrahydrofolate derivatives will also decrease in the cell. So here cell is trapping all the tetrahydrofolate as N5-methyl tetrahydrofolate, and this happens when there is a cobalamin deficiency. So cobalamin deficiency will lead to functional folate deficiency. Functional folate deficiency. Functional folate deficiency means what? Folate is there, tetrahydrofolate is there in the form of N5-methyl tetrahydrofolate. It is trapped inside the cell. It is not able to come out of that form, N5-methyl tetrahydrofolate, because cobalamin is necessary to come out of that form into free tetrahydrofolate. So all the folate inside the cell is trapped as N5-methyl tetrahydrofolate, and that means folate is there, but is there in the form of N5-methyl tetrahydrofolate. So other tetrahydrofolate derivatives are not available, they become deficient. That's why we call this kind of deficiency as functional folate deficiency. So what is the cause for functional folate deficiency? It is cobalamin deficiency that leads to functional folate deficiency. Make sure you remember this important concept, that is called as folate trap, because here folate is trapped as N5-methyl tetrahydrofolate. Now let's move on to see what are the clinical manifestations of vitamin B12 deficiency. We can divide clinical manifestations of vitamin B12 deficiency into hematological abnormalities, which includes megaloblastic anemia, which is similarly seen in folic acid deficiency. Along with megaloblastic anemia, patients with cobalamin deficiency will show neurological manifestations, and also patients will show methylmalonic acidemia or methylmalonic aciduria. These are the three things that you need to look for in cobalamin deficiency. What are the three things? One is you will have to look for megaloblastic anemia. Second thing is you need to look for neurological abnormalities. And the third thing that you need to look for is elevation of methylmalonic acid in the blood or in the urine. Okay, now let's see what type of megaloblastic anemia you see. So if you look at the peripheral smear, the red blood cells that you are going to see here is macrocytosis, that is a big red blood cells with abnormal shape. So macroovelocytosis you are going to see here, which is a kind of a significant finding for a person to show a megaloblastic anemia. Along with that, because why megaloblastic anemia is seen in cobalamin deficiency? It's because cobalamin deficiency will lead to functional folate deficiency, which I just now explained you. It leads to folate trap, and functional folate deficiency lead to megaloblastic anemia. Why? Because folate derivatives, that is N5 tetrahydrofolate, N5N10 methylene tetrahydrofolate, these things are necessary for purine and pyrimidine biosynthesis. So when there is a cobalamin deficiency, there is a functional folate deficiency that leads to decrease in purine pyrimidine biosynthesis, that leads to decrease in DNA synthesis. So the nucleus becomes small, cytoplasm will be big, so it leads to nucleocytoplasmic disproportion, and that leads to big red blood cells and small nucleus there. And that is what is a megaloblast, which is basically oval in shape. So macroovelocytes are is one of the finding that you see in megaloblastic anemia, that is seen in cobalamin deficiency, which is also seen in folate deficiency. Along with macroovelocytosis, the peripheral smear will show teardrop cells, anisopoikilocytosis, that is variation in the size and shape of the red blood cells can be seen. Inclusion bodies like Howell jelly bodies, cobalt rings, basophilic stippling can be seen, and also most importantly, the peripheral smear will show hypersegmented neutrophils. Alright, so this is what we are going to see in the peripheral smear, that is megaloblastic anemia in the peripheral smear picture, where macroovelocytosis, teardrop cells, inclusion bodies, and anisopoikilocytosis, variation in the size, variation in the shape of red blood cell. So now let's see what are the neurological manifestations of cobalamin deficiency. So patients with cobalamin deficiency, they will show bilateral neuropathy, and this is because of degeneration of spinal cord, especially dorsal and lateral columns of spinal cord is degenerated. It is dorsal and lateral column of spinal cord affected here. Why dorsal and lateral column of spinal cord is affected? It is because of the accumulation of methylmalonic acid, which is leading to degeneration here. So the subacute combined degeneration of spinal cord that we see here in cobalamin deficiency is partly because of elevation of methylmalonic acid in cobalamin deficiency. Make sure you remember that. So what are the signs and symptoms that are seen because of subacute combined degeneration of spinal cord, that is dorsal and lateral column of spinal cord which are degenerated? So the neurological signs and symptoms include symmetrical numbness and paresthesia, where we say like tingling and numbness, pricks and needles, that kind of experience, especially in the extremities, in hand and feet, diminished vibratory sense and positional sense, weakness in the muscles, progression to spastic gait, disturbances in the gait which we call it as ataxia. Patient may show like dementia, psychotic disturbances, and even patient may show visual impairment. And neuronal degeneration may be irreversible, particularly when the neurological symptoms have been long standing. Now the other finding that we see in cobalamin deficiency, along with megaloblastic anemia and elevation of neurodegeneration. So the third thing that you see in cobalamin deficiency is methylmalonic acidemia or methylmalonic aciduria. That means excess presence of methylmalonic acid in the blood and in the urine. Why this happens? Because conversion of methylmalonyl-CoA into succinyl-CoA, which is done by methylmalonyl-CoA mutase. So that needs deoxyadenosyl cobalamin. So when there is a decrease in cobalamin, that means there is decrease in deoxyadenosyl cobalamin, and that leads to decrease in the activity of methylmalonyl-CoA mutase enzyme, and that leads to elevation of methylmalonic acid. Because if I want to recap this reaction here, so methylmalonyl-CoA, one of the reaction that we have seen previously, methylmalonyl-CoA, which is coming from propionyl-CoA coming from odd number carbon fatty acid oxidation and variety of other sources of propionyl-CoA, converted into methylmalonyl-CoA converted into succinyl-CoA. And this particular reaction is catalyzed by enzyme methylmalonyl-CoA mutase, and that needs deoxyadenosyl cobalamin. That's the coenzyme form of vitamin B12. So what happens if this deoxyadenosyl cobalamin is decreased? So you're going to decrease this cobalamin. Now that decreases methylmalonyl-CoA mutase enzyme, and that leads to increase in methylmalonyl-CoA, and that methylmalonyl-CoA leads to accumulation of methylmalonic acid in the blood, and which further appears in the urine, leading to methylmalonic aciduria. So methylmalonic acid in the blood and urine, patient will show metabolic acidosis, ketoacidosis, and also it can lead to mental retardation. So all these signs you can see in cobalamin deficiency also. So in cobalamin deficiency, so patient will show megaloblastic anemia, neurological signs because of subacute combined degeneration of spinal cord, and also patient will show accumulation of methylmalonic acid in the blood and in the urine, methylmalonic acidemia, methylmalonic aciduria. So there is a test called Schilling test, although it is an absolute test nowadays, not generally done, but it's more of a research value now. It is a medical investigation used for patients with cobalamin deficiency. There are 4 stages in this test where it will show where exactly the cobalamin deficiency can be seen, starting from the stomach. all the way to the terminal ileum and then into transport of cobalamin from portal circulation to other tissues. So, nowadays sealing test is not generally done because we can measure cobalamin directly and see what is the cobalamin, whether cobalamin deficiency is there or not, and also treating cobalamin deficiency is easy, where you can simply supplement cobalamin and see the improvement in the signs and symptoms. Coming to other uses of cobalamin, especially hydroxycobalamin. Now, the hydroxycobalamin, it is used in something called as cyanokit. Make sure you remember this name, cyanokit. It contains hydroxycobalamin. So, it is an injectable form of cobalamin which is used most often in treating cyanide toxicity. So, how it works? This medication readily combines with cyanide to form cyanocobalamin. So, the hydroxycobalamin, it has affinity for cyanide to become cyanocobalamin, thereby it frees other proteins or enzymes that are bound with cyanide. Because cyanide has affinity for electron transport chain complex called cytochrome C oxidase, and this cytochrome C oxidase, if it binds with cyanide, it's totally inhibiting electron transport chain. So, in order to treat that kind of severe condition, so hydroxycobalamin is used as cyanokit, where this hydroxycobalamin, it's going to combine with cyanide coming from the cytochrome C oxidase and bind with that and become cyanocobalamin, and that cyanocobalamin is taken out of the system and thereby freeing cytochrome C oxidase and thereby allowing electron transport chain to run properly, and that's how cyanide toxicity is kind of treated. So, make sure you remember hydroxycobalamin is part of the cyanokit which is used in the treatment of cyanide toxicity. So, that's all about vitamin B12, that is cobalamin. So, we have covered the absorption of cobalamin, transport of cobalamin, storage of cobalamin, different coenzyme forms of cobalamin, causes for deficiency, deficiency manifestation and diagnosis, and some of the uses of other forms of cobalamin. Thank you.